I'm Majd Saleh. I'm a MediPIET fellow from cohort 2. And I'm going to be taking you through the severe acute respiratory infection Sentinel surveillance in Lebanon. And I'm going to be presenting the findings of the 2 seasons so far. In the past, Lebanon relied on several sources to find acute respiratory infections. However, they rarely had any laboratory confirmation. So the Eastern Mediterranean region from the World Health Organization conducted a mission in 2014 where they came up with a recommendation that Lebanon implement a Sari surveillance system under the pandemic influenza preparedness framework. So the Ministry of Public Health began their surveillance in right after the mission, but the reporting started in December 2014. So the objectives of this surveillance at the national level are to identify circulating influenza strains and detect novel viruses, to describe influenza cases by time, place, and person, to identify baseline figures in order to detect alerts and outbreaks. At the international level is to contribute to global influenza surveillance. So the approach which we're taking right now is the implementation of a new Sari or a Sentinel surveillance system. In Lebanon, it's kind of tricky because we have 6 governorates and we have around 150 hospitals, and 90% of these hospitals are private hospitals. So we have a very big private sector. So in order to select Sentinel sites, we had to take into consideration the private and public sectors and assess them based on feasibility, sustainability, willingness to participate, and trying to cover as much regions as possible. So once we chose our Sentinel sites, we asked the Sentinel site to select a focal point. And that focal point was trained on case finding, specimen collection, reporting, and SOP development. And at the same time, we had continuous insight trainings for site staff, such as residents, head nurses, so that they could all try to assist the focal point as much as possible when finding cases. A pilot test was conducted in 2 Sentinel sites, after which Sentinel sites started reporting throughout 2015 gradually. So we had a gradual start of Sentinel sites. The case definition we used was the WHO standardized case definition, which is severe acute respiratory infection with fever or history of fever greater than or equal to 38 degrees, requiring hospitalization with an onset of within 10 days. Case finding was done through the focal point at the Sentinel site, where she or he receives reports from staff and searches case records at the site's ward. For case reporting and analyses, demographic and clinical data are recorded on a line list, which are later entered on a Sari-specific hospital database using EpiData. The database is shared with the Ministry of Public Health Epidemiological Surveillance Unit on a weekly basis, and analysis is done using EpiData, Excel, and Stata. For specimen collection, we use nasopharyngeal swabs or oropharyngeal swabs, and these swabs are sent to the National Influenza Center laboratory, which is in Beirut. At the national or NIC, influenza A and B types and subtypes are tested using real-time PCR. The results are shared with the Epidemiological Surveillance Unit or the Ministry of Public Health electronically or by fax, and this is done on a weekly basis. And results are fed into WHO's FluNet system. So as a result from this assessment and implementation, we have 12 Sentinel sites in the different regions or directorates in Lebanon. If you look at Beirut, we have a hospital which is put in parentheses because it recently joined the Sentinel surveillance, and its data will not be presented in this presentation. So the data over here is going to be just for 11 Sentinel sites. These are the 11 Sentinel sites, and what I'd like you to pay attention to over here is not the whole table, but just the fact that these Sentinel sites started gradually. So the first Sentinel site started in December 2015, and the last one was in December 2014 and July 2015. But the overall number is from the beginning of January 2015 until November 2016, we have 2,081 reported cases. 83% of these cases were sampled, and 17% of these sampled were positive. The majority were positive for influenza B, 62%, followed by pandemic H1N1, 25%, and influenza A, H3N2, which is 12%. And another thing I'd like you to bring to your attention is that this Sentinel site has the majority of cases, which is around over 30%. The majority of cases come from this site, which is in the southern district of Lebanon. And this is a graph just to show the positive influenza cases and how they're distributed throughout the weeks. We see the beginning of 2015, we have a lot of the cases tested positive for influenza B. Until the end of 2015 and beginning of 2016, we had a cluster of pandemic H1N1, but then influenza B took over. Up until now, we don't have any positive cases. Also to bring to your attention that the majority of our cases are children less than 5 years of age, so kind of similar to the results Dimitru presented before. And the majority were males, and 18% of these influenza positive cases had chronic conditions. So as a discussion, I'd just like to compare these two seasons. The first part is the reporting. The beginning of the Sentinel surveillance was gradual. However, by October 2015, we had all Sentinel sites reporting. And this brings us to seasonality. The first season was kind of incomplete, had incomplete data, so we couldn't really test when the season started. But the second season, according to our data, showed that the peak started in October 2015. But of course, we need more time with the surveillance to really understand the season. Those at higher risk were children less than 5 years of age, and most of them resided in the southern district of Lebanon. The highest circulating influenza types was influenza B at the beginning and continued to be influenza B, but we did see a cluster of influenza A H1N1, pandemic influenza H1N1. So the strengths of this is that we actually implemented a new surveillance system, which wasn't there before. And we tried our best to select Sentinel sites that could produce high quality data and be sustainable. 83% of our reported cases were sampled, so we tried to sample as much as cases as possible. And we had a positive yield of 17%. The limitations, though, is that we still don't know for sure the representativeness of our Sentinel sites. We haven't done any test or study to test the representativeness of these Sentinel sites. And we do not have any incidence rates because it's really hard defining catchment areas for denominators in Lebanon. So as a conclusion, the first 2 seasons of Sari surveillance in Lebanon gave us an understanding of the epidemiology of Sari and influenza, and the circulating influenza viruses in severe cases, and an idea of influenza seasonality in the country. And it's also essential data to provide to the overall global influenza databases. Our recommendations, however, for the progress of Sari activities to meet the proposed objectives is to define an approximate denominator for calculating incidence rates, to estimate the burden of influenza in Lebanon, to continue this surveillance so that we could have baseline data to define alerts and thresholds to compare severity between years and localities, and to inform, of course, on the long run, to inform national policies such as priority groups for vaccination and treatment. And I'd like to acknowledge all these people on the slide, from the Sentinel sites to the laboratory to WHO and MediPIET. Thank you.
Thank you very much, Majd, for very well structured presentation and comprehensive one. Congratulations. And I would like just to add that using the standard case definitions for Sentinel surveillance, it's very important because countries accept to share their data to the international platform, Global Influenza Surveillance and Response System, managed by World Health Organization. And this opportunity give us a chance to see not only the trend of the data at the global level, but also being part of the international being part of the international platform increase a lot the local data. Thank you again, and now floor is open for questions and discussions. Please present yourself.
Isa from Palestine. Thanks, Majd, for this very interesting presentation, actually. But I have here a question regarding, because you are comparing two seasons, 2014, 2015, and in order to estimate also the burden of the disease or the burden of influenza, could you please mention or clarify to us the death cases between the two seasons in order to see which severity is more in that between the two seasons? Thank you.
You're asking about death cases?
Yes, death cases.
Yeah, so in the first season, if we're going to talk about severity, talking about influenza positive cases, I think it's, I think so far we've only had one death case, which was confirmed H1N1. And most of the deaths were chronic conditions. So we only had in the first season, the beginning of the second season, which was, if I could open up the, so I'm just gonna narrow it down to those that were confirmed. So we only had, at the beginning of the second season, did we have a death case that was confirmed influenza and had chronic conditions. The rest were not influenza positive, and they also had chronic conditions. We still don't have, I don't think we have enough evidence to prove that one season had more severity than the other, because as I mentioned, the first season was a gradual start. And so it's really incomplete data to actually be able to compare. Yeah.
Thank you. Vladimir first, and then Sylvia.
Okay, thank you for the wonderful presentation and the data presented here. My question is regarding, again, the severe acute respiratory infections among children. As we heard in the previous presentation, you have the highest incidence there. But I think that you mentioned one very important point is that 80%, if I'm right, were with chronic medical condition out of these children. Is that right? So if that's so, maybe then we can adjust the attack rate among the children. Sorry. So if I heard correctly, the 80% of the children had a previous health condition. Is that right? Or
Yeah. So these are all the influenza positive cases. I'm just, and these variables are not related to each other, so the chronic conditions is for all age groups and not just for children.
okay.
Yeah.
Sylvia, please.
I just want to ask you, because you said you cannot make estimates. Is it difficult when you did the selection of Sentinel sites to analyze the catchment area and the population subgroups? Because sometimes for selecting Sentinel sites, it's a request.
Yeah, so Lebanon is a little, I don't know if it's unique, but it does have a problem with defining catchment areas in general for hospitals, because there's no centralized form of hospitalization. So people from a very far away district could come to the capital or elsewhere even to be hospitalized. So defining the catchment area in general is really hard. So when we chose our Sentinel sites, we just tried to have them representative and feasible, and possibility of them being sustainable more than just the possibility of finding a catchment area, because in general in Lebanon it's really difficult.
Sorry, time is running. The last question. Please, Doctor. Okay.
Thank you for the presentation. Just
our
a short
colleagues
question.
Okay.
Yeah, just
Short,
do you have a Sentinel site for the immigrants or refugees in your country? Just for information.
No, but you know, it's a nice question because this Sentinel site, which I told you has the highest number of cases, is very close to a refugee camp. So I don't know if this might explain the high numbers over here, but we do not have something specific for Sari surveillance in particular. We do not have anything specific for refugees, no.
Okay, thank you. And last question.
Okay, thank you, firstly. And my question is, firstly, you use as denominator admission to hospital, yes? What do you use for denominator?
Well,
because you mentioned that catchment area, defined catchment area is really difficult, is really tricky. Okay.
Yeah.
And on the other side, you use admission number of admission to hospital?
Yeah, that's what
Okay.
we're going to do. But the numbers we presented over here are counts, are just numbers. They're not rates or
Okay.
percentages.
Okay, and the second one, you mentioned 12 hospitals. Yes, did you include hospital for children? Could you clarify characteristic of this hospital?
So these hospitals are all they're not specialized hospitals.
General hospitals?
Yes, they're general hospitals. They're not
Okay.
specialized hospitals, and they're divided between private and public hospitals.
Okay, and this general hospital cover adults and children?
It covers all age groups.
Okay.
Yes.
Thank you.
Okay, thank you very much.